our talk. Um, we are in the classes extending from the previous lecture. We are going to discuss about the common ECGs that are given in your IVA exam. In previous classes, uh, we have discussed the common ECG presentations or ECG findings of atrial fibrillation, supraventricular tachycardia, ventricular fibrillation, and these three ECGs should be diagnosed on the ECG strip the very day of your examination. It's important. And for this diagnostic workup from the ECG findings, we have already given you the clues, and if I recapitulate these findings again, I can go through these ECGs. This is the ECG of atrial fibrillation. How we can tell this is the ECG of atrial fibrillation? First, when you have the ECG in your hand, you just look at the rhythm strip. This clearly shows the ECG is irregular, as the distance between these two R wave and these R wave is not similar one. This is more, this is less, this is gain more, this is more, this is less, so it is not regular. This is irregular ECG. Okay, irregular ECG. And you can find the P wave here. There is no sinus rhythm. Okay, the rhythm is irregular. There is absent P wave. No P wave. No P wave. And when you search for the P wave, you just look at the QRS complex, and before that, whether there is any upright deflection, the lateral lead or anterior leads. It is a 2, 1, 2 ABL and V1 V6. There is no P here. No P. So when you are getting an irregular pulse or the ECG, you get the irregular rhythm and absent P wave. The diagnosis is, unless otherwise proved, it is atrial fibrillation. Okay, so this is an atrial fibrillation. The more ECG findings in this ECG strip is that way, the E1. Here, a classical picture of a sawtooth appearance. Sawtooth means the tooth of a saw. পরাতের দাঁতের মতোই হয়ে আছে. These are the even wave, the P, and the regular one. So this is the flutter wave. This is not the fibrillatory wave. This is regular one. You can see that. If this sawtooth means the irregular one, this is a fibrillatory wave. But this is the flutter. So here, what is the ECG findings? You can tell that irregular rhythm, absent P wave, and there is a flutter wave in the Q1. These three is enough. Pass the exam. What is the diagnosis? Diagnosis is atrial fibrillation with atrial flutter. Okay. And if you get a complete one, you just calculate the heart rate before you telling the diagnosis. If you are smart, you I think very well know how to calculate the heart rate from an irregular ECG. This is the rhythm strip here. From that, you can easily calculate the heart rate. Keep in mind, because the next questions you may be asked, what is the heart rate here? Then you have to tell the heart rate. If your calculation is wrong, then your examiner will ask how you will calculate it. And it becomes a more puzzle one. So be sure that your calculation is right. Okay. If the heart rate is more, then you can tell the diagnosis is the first atrial fibrillation with atrial. This is a complete diagnosis, and you will get full marks for that. And I think if your diagnosis is correct, ECG findings is correct and you can answer the relevant questions regarding atrial fibrillation, you will pass the viva of that particular book. Okay, so this is atrial fibrillation. The questions here. After you have given the correct diagnosis of atrial fibrillation, you will be asked how this atrial fibrillation patient will present. How this patient will present. What is the presentation? This is the number one. Sometimes you have examiner before you being given the ECG strip, a scenario of that particular patient's being told beforehand. 55 years old or 65 years old young old man presented with chest pain, and for several hours, okay, and palpitation, chest pain and palpitation, and ECG has been done. The ECG shows like that. So you can give any picture. Okay. Sometimes it may be given the hypertensive man presented with that ECG. Okay. Sometimes a scenario like that, 40 years old female presented with palpitations and sweating because it's goiter in front of the neck, and ECG has been done. It has shown that the ECG is like that. This may be a scenario. Okay, the scenario-based questions may also be asked in your ECG exam. Okay. So the presentation of the atrial fibrillation will be like that. There is a patient may be asymptomatic. No complaint here. ECG has been done for other reason and it is revealed this is atrial fibrillation. Sometimes patient may complain of only palpitation. This is episodic one, paroxysmal one. For a certain period of time, he or she felt palpitation, and a few moments later, it becomes okay. It may be a findings also. Sometimes patient may present with features of that particular causes, particular disease that causes atrial fibrillation. Patient may present, as I told earlier, scenario of thyrotoxicosis. Yes, sometimes presents with hypertension. Patients in ischemic heart disease. Hypertension, ischemic heart disease. Patient may have tubular heart disease. Patient may have cardiomyopathy. These are the causes. Sometimes a topic of question may be asked. What are the causes of atrial fibrillation? We will utter the name. That is hypertensive heart disease, ischemic heart disease, tubular heart disease, thyrotoxicosis, ischemic heart disease. All these can atrial fibrillation. And no cause maybe for atrial fibrillation. Idiopathic one. It is also the important causes of atrial fibrillation. So these are the causes and presentations. Asymptomatic, episodic in nature palpitations like that. Sometimes you get the clinical features of the particular cause, and sometimes you get atrial fibrillation with complication of the atrial fibrillation. The atrial fibrillation patients present with ischemic stroke. So if you answer in that way, you can convince the examiner that you know the causes well, you know the complication of the patient well, and you already told the ECG. So it will be a complete answer. When you were asked what are the clinical features of that particular patient, you go for asymptomatic one, go for the causes of that atrial fibrillation, go for the complication of that atrial fibrillation. You, with the clinical feature, you touch the three domain of the presentation of atrial fibrillation. Okay, then you can cover three questions: the causes, the complications, and the clinical features of the particular ECG. Okay, then we ask what next you will do. Patient has got the scenario like that, ECG is like that, and what next you want to do? Very relevant questions. When you are to get a patient with ECG like that, what will be? Is that it? So we search for the history, we search for a clinical proof, and we go whether there is any complication of that particular patient. Then you will find out the treatment plan. If the patient has gotten paroxysmal one, paroxysmal atrial fibrillation, asymptomatic or symptom is quite tolerable for that patient, and he or she has got no risk factor for any cardiac diseases like hypertension, like diabetes, valvular heart disease, ischemic heart disease, any other issue. It's okay. If the atrial fibrillation is associated with risk factors of cardiovascular diseases, atherosclerotic cardiovascular diseases, then you have to treat the patients. If in a symptomatic one, if the symptoms are tolerable, it should be treated. Treated for what? Whether the atrial fibrillation comes with thromboembolic manifestations. Okay, these are treatment complications. Number one. Number two, if the patient has got any cardiac diseases, then you have to treat the cause. Number three, already if the patient has got any complications, then you have to treat with prevention or treatment of the thromboembolic diseases. Like atrial fibrillation present with stroke, you treat the stroke, and you also treat the patient to prevent whether the stroke did not becomes recurrent. Okay. Then comes for the atrial fibrillation itself. If the rate is low, then you have to make the rate low. If the rhythm, you have to brought back to this irregular rhythm to sinus rhythm. Okay. So there are many drugs for the rate lowering, beta blocker, digoxin, inhibitor. There are some drugs for reversion of these irregular rhythm to sinus one. For this, there is chemical cardioversion and there is electrical cardioversion. Okay, electrical cardioversion means DC shock. If is atrial fibrillation patient present with hemodynamically unstable one, patient has got features like shock. You are getting no pulse, you are getting no blood pressure. In that case, you have to go for the DC shock. Okay. And if this sinus sinus rhythm, you go for the chemical cardioversion. Some drugs, immunity is one of them. Lecanite, another one, and you just name some example drugs, examples, and decision. So these are the book of answers you should be ready with. Okay. Then some advanced questions may be asked if examiner a choice when you will go for the chemical cardioversion, when you will go for the electrical cardioversion, or the condition you should check for chemical cardioversion. What is the treatment of the persistent atrial fibrillation? These are the advanced level questions. I think those who are very much smart one, all these are written in divisions. You can go through this. Unless so far I have discussed, it is enough to pass the ECG of technique. Again, look for the rate of the ECG very high. Isn't it? One large square between these two are. So it's almost near about 300. Isn't it? One large, so one and a half. One and a half. That means 200. One and a half. 300 by 1.5. Almost the heart rate is 200. But here the distance between the successive R wave is EM, which is regular. So you get an increased heart rate, but regular rhythm. Again, P wave here is absent. You can't find any ECG. QRS complex with a P wave. No P wave. No P wave. There is absent P wave. So when you get an increased heart rate, but regular one, but absent P wave, this is SB, supraventricular tachycardia. This simple meaning, supraventricular tachycardia. The confusion arises with this SPT, whether it is a sinus tachycardia or not. This question may be asked. How you differentiate this SVT from sinus tachycardia? The question answer is very simple. That is the P wave. When you get the P wave with a regular rhythm, increased rhythm, as it is tachycardia, but with the P wave present before QRS complex, this is sinus tachycardia. Another point is that sinus tachycardia, the rate is not that high of supraventricular tachycardia. Another point, but main point is you will get increased rate tachycardia regular, but there will be P wave present here in case of sinus tachycardia. But supraventricular tachycardia, you will have the clearance. Again, in the supraventricular tachycardia, usually P wave is present here, but when the heart rate is more one, P1 complex becomes superimposed on the P wave. So P wave becomes masked drug. Again, supraventricular tachycardia means this the rate being generated from the ventricle. Sometimes it may not be true. Sometimes the ventricle may be part of the rhythm generation site. Okay, this lesson is when you get an increased heart rate of regular rhythm, absent P wave, you will call it a sinus supraventricular tachycardia. And when there is P wave present preceding every QRS complex, then this is a sinus. Okay. In case of supraventricular tachycardia, you will have the QRS complex and narrow one. In white. When there is a ventricular tachycardia, you will get the QRS complex wider. Just take a look. Yeah. Yes. You find this QRS complex white. These kinds of white QRS complex is usually generated from the ventricular tissue or ventricular junction tissue. Whereas atrium or tissues above the ventricle generates QRS complexes in narrow like that. So narrow complex tachycardia, you will get the atrial supraventricular. Okay. If there is white complex tachycardia, you will get the ventricular tachycardia. You get in part. This is a supraventricular. And then what is the rate? Before telling the diagnosis, you calculate the heart rate previously. If the examiner asks what is the rate, you can tell, yes, this is the rate. Okay. Again, supraventricular tachycardia, how the patient presents, what causes supraventricular tachycardia. Supraventricular tachycardia is short-lived one. Sometimes it may be present with anxiety. The male patients may present with palpitation for a few moments. Later it becomes okay. The patient settles down. Maybe with the patient. Sometimes supraventricular tachycardia patients present with hemodynamic complication. You get the pulse rate very high, blood pressure is very low. Sometimes supraventricular tachycardia present with an aberrant contraction. You have an aberrant contraction pathway in the junctional tissues, and you get a presentation of that aberrant contraction as SVT. This may be a so sometimes it may be part of anxiety. sometimes facilitating in presence with some people chance. Chance that increases the heart rate. It may also cause anxiety. Okay. Now the patient presents with palpitation. Sometimes patient may have sweating. Sometimes patient may present with polyuria. Sometimes may present with other features of anxiety. Sometimes patient presents with features of shock. These are the presentations. What will you do when you think there is increased heart rate? Definitely you will go for an ECG, and that is given here. Okay. And if the patient has got a very increased heart rate with a low blood pressure, you straightforward go for the salvation of the patient. It is treatment of the patient, other than you become studied with other investigations. Rather, you go for the treatment. What is the treatment? You have to quickly work the heart rate. For this, vagal inhibition is that you have to make that vagal inhibition happen to go for the carotid sinus message. How this carotid sinus message is given? It has been taught in your word, in your lecture classes, in your literature classes. Like myself, that's taught you this. Is that it? The carotid sinus message. This will burn down the rate of the heart. If not, then if the patient has got hemodynamic compromise, you have to treat the patient's CC. Yes, CC. And with that, you go for the IV continuously. It may be repeated within few seconds. If the heart rate not being lowered, blood pressure not being restored. If not, if it is failed, then you go for the PC shock also. Okay, this is an emergency. If not, if patient is not presently doing hemodynamic function, then you will carotid sinus message reduces the heart rate. You straightforward go for any causes. The SVT, supraventricular tachycardia, and treat the causes. And for the prevention of the SVT, you may give some rate lowering drug to patients. Rate limiting procedure. Okay. So these are the treatment options. And for advanced level questions, if there is a volume contraction, what we will do? I think it will not be in the domain of previous ones. This is enough for SVT. This SVT, very popular question here. How will you differentiate this from atrial fibrillation? How will you differentiate this from sinus tachycardia? Because all these are atrial, that is narrow-complex tachycardia. Atrial fibrillation, narrow-complex, supraventricular tachycardia, narrow-complex, and ventricular tachycardia, wide-complex. Okay. So this is SVT with the relevant questions. I'd rather take a break for a while, and that time you may ask any questions if you have. I told you previously, so wide complex tachycardia. Just see the ventricular complex is quite wide. There is absolutely wave, but it is regular. This is ventricular. This is the spine neck. Okay. This is the ECG of the ventricular fibrillation. Difference between this, here you get this is an irregular one. The axis not being aligned. Some axis is positive, some axis is negative. So if you go through the book, you will get the 2 point that is capture beat and future beat. It is also there. This one. you just notice that point that is you should be captured. You need not mention this in Viva as you will not be asked with these type of questions. Rather, you have to examine these sorts of issues. Ventricular tachycardia. Ventricular tachycardia. Why this is ventricular tachycardia? Because the QRS complex is wide, heart rate is more, and there is self-image. So this is set up diagnosis. Okay. The ventricular tachycardia section. Some questions are asked what the cause of ventricular tachycardia, how the patient will present. It is an emergency one. This is a cardiac emergency. We have to treat the patients in CCU. Okay. CCU, if the patient with cardiovascular collapse, will immediately go for the PC shock. An important life-saving measure. Okay. Important one. And then you have to revert the process to the ventricular. Again, all the cardiac disease may be ventricular tachycardia, ischemic heart disease, cardiac pulmonary heart disease, doing some electrolyte imbalances. The important one. So if is there, you have to revert the process. Simple questions that are asked from that particular ECG. Okay. Another go for it, another. This is one. This is an important issue. What is the example? Again, you look for this rhythm stroke. That is the lead 2 here. B1 also has been shown with a long strip. B5 also has been shown with a long strip. Okay? We go to lead 2. Here, you see is ECC, one QRS complex. This is another QRS complex. This is another QRS complex. This one belongs. This. The RR wave being widely spaced here. Widely spaced. There is 1, 2, 3, 4, 5, 6, 7, 8, 9. The 9 large square between H2 R1. Again, there will be 9. There will be 9 if you calculate this. There will be 9. So, RR interval is regular there, but widely spaced. Widely spaced means the heart rate will be much lower. If you divide 300 by this 8, 300 by 8, you will get 35 heart rate. Only 35 in the severe bradycardia. When you get an ECG of a severe bradycardia, first you rule out whether it is associated with complete heart problem. This is important. You should explore always. Sorry. Follow. Email word. আমি ক্লাসে ছিলাম রে ক্লাসে ছিলাম কামাল স্যার আছে কিনা দিয়ে দেখতে পারো আমার মনে নাই আর ইয়ে কি বলে এটা আমার ধরো কিছু করিব না এখন হার্ট ব্লক দিতে পারে হার্ট ব্লকে কিছু পাইছো কিনা হার্ট ব্লকে কিছু পাইছো আচ্ছা না থাকলে তুমি স্ট্রেট ফরওয়ার্ড একটা আমার চিকিৎসা দাও আর ওকে গুড ভেরি গুড আর একটা শিশু আচ্ছা ঠিক আছে ওকে প্রেশার কত পাইছো প্রেশার শিশুটা একটা কল দিয়ে কল দাও আর আমি 10 মিনিটের মধ্যে আসবো তো না কল দাও সিএর কল Sorry for the interruption because that was an emergency also. My patient in my ward. Okay. So this is ECG of complete heart block. Uh, you get here that is severe bradycardia. When you get any ECG of severe bradycardia, you just rule out complete heart block first. Or rule out the complete heart block. You just make a note of the R internal, which is regular here. You make a note of the PP internal. This is the P. This is the P. Make a note. This is P. This is P. It's regular one. Almost 2, this is almost 2, this is almost 2, this is 2, that is PP internal and also regular one. But you go for the tear interval here. The tear interval is quite short here, but tear interval is quite long here. This is variable tear interval. In other words, the P and QRS complex are not associated. Usually, the sinus rhythm, that is the rhythm generated in the P wave, it transmits through the junction, which is the ventricle, creating ventricular complex. This is the P wave in the sinus as a node, is the P wave, and when this P wave is generated to the ventricles and produces a ventricular complex, this QRS complex, this P QRS complex. Okay. Here, P, no QRS. Here P, no QRS. Again, this P QRS. So, no association. The complete dissociation between P and QRS. So, this is complete. You get these types of ECG findings. This is the complete heart block. And when you get an ECG of complete heart block, you try to make a search for inferior. Sometimes inferior MI is commonly causes. We go for the inferior lead, then 2, 3, then there is no Q there. So, no ST elevation here. 2, 3, so there is, in your exam, usually you are tested with a simple maths. Double definition, usually not given. So, but in your clinical practice, you should make a note of that. So this is the ECG of the complete heart. Again, how these patients may present. This patient may present with reduced heart rate. Patient may present with syncope, recurrent fall as their heart rate is low. So the cardiac output will be low. Supply to the brain, supply will be reduced. One patient will get a features of syncope, lightheadedness. Okay. And sometimes patient may present with the features of the causes, the ischemic heart disease, with chest pain. These the features. Some chronic diseases, tuberculosis, infective endocarditis. These are also causes of common one in the old age, the idiopathic fibrosis of the junctional tissue. What is the complication? See, these are the causes. How? What is the treatment here? The treatment being you just group the patients, whether these complete heart block patient presents with hemodynamic upset or not. If there is hemodynamic upset, you have to treat with a drug to increase the heart rate, like atropine or isotretinoin. And if not, it should stay hemodynamically unstable. You got temporary pacemaker. And later, it will be replaced with permanent pacemaker. Okay, the hemodynamically stable, only heart rate is reduced, just increase the rate with control. And if this inferior MI is associated with MI, that is the inferior MI, you just treat the inferior MI first. Then the complete heart block may reverse. If not, if associated with hemodynamic unstability instability also, then you go for a temporary pacemaker. Later, replaced by permanent pacemaker. So these are the mode of action. How will you tell shortly about the management plan for complete heart block patient? Okay. So this is the ECG I need to talk about. Beyond that, the ischemic ECG, that is Duremai. And I think I have discussed this in the hospice station, because in the hospice station there was ECG of mind. So the ECGs that are usually given in your exam already been discussed. They could be generated also. If there are any questions, you can ask me. If not, I have to conclude. I have to work now. So there is an emergency patient here. Okay. There's no question. Then we conclude here. I want to draw attention of your monitor. If you have any suggestion regarding the topics of the next classes, please make a call.